And we are live. Welcome everyone. In healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space to ask your questions and share our nursing perspective without taking too much of your time. Today, we'll talk about BPH. We'll be discussing what is BPH, the signs and symptoms, the diagnosis, and the treatment opportunities. If you're new here, welcome to the Melanin Initiative. I am Alicia, and I co-host the Melanin Initiative along with Kimberly and Geraldine. We are a health literacy podcast offering our nursing perspective. When we say health literacy, we're talking about the ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. By watching on YouTube or listening on your favorite podcast app, we hope you feel empowered to ask questions, educate on how to manage your health, and confident to navigate the healthcare system. If you haven't already, subscribe so you can be notified when we release a new episode. Thumbs up the video and leave a comment or two. It helps us help you. It also shows YouTube that this content is valuable and helps to make sure YouTube shows our content to those that need to hear it. As a reminder, this show is for educational purposes only. The opinions expressed are our opinions alone. They are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. And if you're having a mental health emergency, you can call 988 or text 741-741. All right, Geraldine, go ahead and get us started.
All right, so today we're going to be talking about BPH, which is also known as Benign Prostatic Hyperplasia. So first we'll start off by talking about what exactly the prostate is. So the prostate is a walnut-shaped gland that is part of the male reproductive system. The main function of the prostate is to make a fluid that goes into semen. Prostate fluid is essential for a man's fertility. The prostate, as far as where it's located in the male, it's located directly below the bladder and above the muscles of the pelvic floor. So hopefully, if we can, we'll put up a picture depicting the anatomy just so you can get a visual of what I'm talking about. Regarding its location, the rectum is directly behind the prostate, making it possible to actually feel the gland from the rectum using a finger. Usually providers will perform, well, we'll get into this as well, but some providers will perform a digital rectal exam which feels for the prostate gland. The ducts in the prostate gland flow into the urethra, and the urethra is the, hopefully once again we'll have a photo, but it's the tube, not tube, is that the word would you use, that the urine passes through?
Yeah, tube sounds good.
Yeah, tube, which passes, so the urethra passes through the prostate, but the urethra is also where urine exits the body. So moving right along.
I'm going to talk a little bit more about BPH specifically. So as Geraldine said, BPH stands for Benign Prostatic Hyperplasia. It is a non-cancerous enlargement of the prostate that may cause difficulty in urination. So to kind of describe this a little bit further, throughout their lives, men born as men produce testosterone, a male hormone, and small amounts of estrogen, which is a hormone. As men age, the amount of active testosterone in their blood decreases, which leaves a higher proportion of estrogen. Scientific studies have suggested that BPH may occur because the higher proportion of estrogen within the prostate increases the activity of substances that promote prostate cell growth, right? So all of that to say, sometimes the hormones make your prostate grow. There's another theory that DHT, which stands for dihydrotestosterone, which is another hormone, plays a role in prostate development and growth. So some research has indicated that even with a drop in blood testosterone levels, and you should go back to our testosterone episode, so even with a decline in that level, older men continue to produce a high DHT in the prostate. The accumulation of this DHT encourages prostate cells to grow. So of note, BPH primarily affects older men. And then on average, BPH affects 50% of men between the ages of 51 and 60. And in addition, it affects 90% of men over the age of 80. So for our purposes, it's very common.
Yeah, and we saw it a lot in the hospital
Absolutely.
setting.
Yeah.
Yeah, and so we're going to go over the signs and symptoms of BPH. So when we say benign, we're talking about not cancerous. Because typically when we think of cancer, we're thinking about a cell that's larger than it's supposed to be. And so we're always trying to decide, is this going to lead to something that grows uncontrollably, cancer that we have to treat, or is it benign and then we just manage the symptoms, right? So, and then prostate refers to the gland itself, and then hyperplasia, hyper meaning enlarged growth. So typically you might experience that you're urinating more often than usual, so 8 or more times a day. The urgency, meaning that you really have to, you're probably running, or you're not even leaving the house, or you're sitting next to the bathroom when you go out to eat. Or at nighttime you're running, you're not waiting for your nurse to take you to the bathroom, you can't get the urinal in place fast enough, you're not able to control the urine from leaving your body. You might have a weak stream, we see that a lot, and I don't know that, you might notice that, it might even be something that happens so slowly over time that you might not notice that. Unless someone brings it to your attention. Difficulty starting, call that hesitancy, so your bladder is full, you've gotten to the toilet, or the urine. What is that? Is that
urinal?
Too?
Yeah, urinal. It is a urinal.
The commode.
And then you're just standing there waiting, right? And I know as a nurse, I've witnessed that so many times where you're just
waiting.
And they apologize, and they're so, they feel bad that you're having to wait. But that's just part of the aging process too. Dribbling at the end, definitely see that a lot. And so it's really important, especially if you're nursing care of that patient, that you're checking the linen and the sheets, or even if you're at home taking care of someone, because oftentimes they'll finish, but then be a few more drops later. And we see that because men will then have toilet paper and tissue kind of stuck to their penis and all over little spots, or they'll ask for towels or washcloths, and they'll kind of just sit it there, and over the course of time it ends up being saturated, because if you're going 8 times a day, those little drops add up. And then the sleeping, because once they lay down, it's like the gland gets a chance to actually open up, and so they tend to pee more at night than in the daytime. Incomplete emptying of the bladder, and so there's something preventing the urine from going all the way, so the bladder never empties, and that's actually why you keep going back, because the bladder hasn't completely emptied. And which is, we'll talk about soon, about one of the medication options is to help open up that tube. Interrupted stream, so go, stop, go, stop, go, stop, go, stop. Straining, which we always want to avoid. And then incontinence, your ability to stop the urine before you're able to make it to the bathroom. That could be physically, because maybe you have some kind of weakness, maybe there's something in the way, those kind of things. Pain after ejaculation or urination, and then unusual smell or color to the urine itself. Some symptoms often come by that blockage, or the bladder's just working so hard to pass the urine through that blockage that it leads to those symptoms. The size of the prostate does not always determine the severity of the blockage or the symptoms that you have. It's quite common for some men to have a really large prostate and have very little blockage and very little symptoms, while other people who have male body parts have minimally enlarged prostates, and they might have a greater number of symptoms and a much larger blockage, and you won't know that until you go get seen by your provider.
So who is most likely to develop BPH? Men with the following factors are more likely to develop BPH. This includes men age 40 and older, those that have a family history of BPH, those that have medical conditions such as obesity, heart and circulatory disease, and type 2 diabetes. Also, lack of physical exercise puts you more at risk. And those that have erectile dysfunction are also at a higher risk to develop BPH.
And so we talked about going to see your provider so you can get diagnosed, and that provider might be a physician or MD, nurse practitioner, NP, or physician assistant or associate PA. And we're going to ask you about your own history. When did you notice these symptoms started? How often? Other things we talked about: burning, pain, difficulty going, difficulty stopping. Anyone in your family? You would have to have a lot of men talk about that.
Wow.
So that's a tough one. But hopefully, I do see a lot of younger men talking now, being more open and recognize the importance of sharing. So hopefully through your family and the communities that you're a part of, you're getting more comfortable talking about your experiences. Because I could see where for some men, they might feel that it's like a sign of their masculinity.
Right.
Yeah.
And it's not. And we certainly don't want you to feel that way. Perform a physical exam, as well as maybe run some blood tests and maybe take a urine sample, especially if you're reporting odor and change in color.
Mm-hmm. One thing I wanted to mention, Kimberly talked about, the different types of providers that can diagnose you. I will say for some of the more complicated, BPH is so common that usually general practitioners of any kind can diagnose and treat you. But for the more complicated cases, you may get a referral to go see a urologist, which is someone who specializes in bladder and prostate as well. So
yeah, good point. And in that office, they might have an NP or PA working.
They could.
As well.
Yeah, actually, one of my clinical rotations when I was in NP school.
Oh, yeah, I remember that.
Yeah, my first clinical rotation, the provider that I was with, she actually was an NP, and she worked at a doctor's office, but she was one of the providers seeing patients. So, yep. How is BPH treated? So one of the most common forms of treatment is medications. That's usually like the first line. I'll go into the different types of medications. There are a class of medications called alpha blockers. They include meds like Flomax, which is probably the most common one that I've seen in practice that's used. But there's also some other ones, Uroxetrol, Cardura.
That's popular too.
Yeah, Cardura. I've heard of that one a lot too. But typically Flomax is the one I hear. But essentially these medications, these alpha blockers, they relax the muscle of the prostate and bladder neck, which makes it easier for men to pass urine.
And empty the bladder.
And empty the bladder, yeah.
So you don't have to keep
going back, right. Mm-hmm. Another common medication class is the 5-alpha reductase inhibitors, and these drugs include medications like finasteride, also known as Proscar, as well as dutasteride or Avodart. And these medications, they actually shrink the prostate by inhibiting hormonal changes that cause the prostate to grow. There is also combination therapy, which includes using both of the medication classes that I just mentioned, which are the alpha blockers and the 5-alpha reductase inhibitors, which provides more significant symptom relief. And then another one that I actually was unaware of until recently was that Cialis, which is used typically for erectile dysfunction. It can also be used to improve BPH symptoms.
Is it being used off-label in that way?
Not that I've seen in practice, but
is it top indication?
For say that again.
Cialis, is it being used off-label for BPH, or it is an indication?
I think not that I haven't seen it in practice as being used off-label for BPH.
I'll find out.
Yeah. So other medications that we see used in practice are alternative complementary supplements. A very common one is saw palmetto. It has been extensively studied for urinary symptoms due to prostate enlargement. However, 2 large NIH-funded studies found it no more effective than a placebo, which that's pretty interesting. Despite various preparations and some low-quality studies suggesting benefits, no saw palmetto product has conclusively proven effective for BPH, although we do see it commonly used. There's limited research on saw palmetto's effectiveness for other conditions, and it's generally well tolerated with mild side effects like digestive symptoms or headaches. It doesn't affect PSA levels, which is we do PSA test, which is a blood test that looks at the prostate hormone levels. Is that what it would be? PSA levels.
Yes.
Yeah, okay. And that PSA is used to screen and monitor prostate cancer. However, as far as Palmetto is concerned, its safety in women, children, or during pregnancy and breastfeeding remains uncertain, because although it's used in the BPH realm and in men with BPH symptoms, it also has other uses that it would include the female population, which is why we kind of put that disclaimer there. Important considerations: if you're experiencing urinary symptoms in general, make sure you contact your healthcare provider, as these can indicate serious conditions like prostate cancer. It's very important to just seek medical attention in general, because it may not even be, it could be something else. STIs sometimes can also have similar symptoms. So just bottom line, always contact your healthcare provider, or reach out to your healthcare provider and see them, so that they can eliminate and rule out other conditions and figure out what's going on.
Hi, I'm Alicia from the Melanin Initiative Podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Always discuss any complementary health approaches with your provider as well, so that you can make informed decisions together. So if you are taking complementary supplements, always provide that information to the healthcare provider, because we have found that some supplements may interact with other medications. So although you may hear online, or your family member may tell you, hey, this is good for this, always tell your healthcare provider what you're taking.
Yeah, I think that's a super important point. When you talk about complementary, so this information came from the National Institute of Health right here in DMV. And so we're talking about like a supplement. And so we have kind of what we call conventional medicine, which is all those medications that you need a prescription for. And then what we could also call complementary alternative. So the National Institutes of Health has a branch or a division devoted to complementary and alternative medicine, known as CAM. But I noticed they also recently adjusted the name to be complementary and integrative, which we've started to reveal, started to talk about on this show, both integrative and functional medicine. And so just wanted to point that out, because I know there's a lot of people that don't want to take prescriptions. And so that's just a credible resource for you to go to, so you can learn more about it. And so when we talk about those interactions, we're talking about the medication that you're taking. Maybe it's making it less effective or more toxic, in the more toxic or cautionary levels in your blood system. And so that's what we want to know. It doesn't mean we're going to make you stop. We just want to talk about it. Maybe we'll talk about, we'll take this then and take that there, or let's pause this so you can try that. We just want to, it's always about your safety. And then I did check it out. So Cialis, so some medications, like let's say Tylenol, we're going to use it to treat your headache. But then we noticed some people have taken Tylenol for 6 months and now their hair has grown back. So then we say, okay, now we're going to prescribe Tylenol for hair loss. That would be an off-label use of the medication. But for this Cialis, because we all do know it's for erectile dysfunction, actually a primary indication is BPH. Yeah. And sometimes when we use things off-label, there's still a lot of safety data for it, but maybe your provider has to, the way they write the prescription has to vary so that insurance will cover it. Because if FDA has approved it for one thing, like BPH, and it wasn't an indication, then your provider might have to make it sound like you have BPH, or that when they talk to you, a lot of times they'll talk to you and say, look, I'm going to prescribe you this medication, insurance is going to cover it. But when you go Google it, you're going to see all these other side effects, because it's not, it wasn't FDA approved for this, but we've still used it in tens of thousands of people with very minimal complications, because we're using it off label. Kind of like when we talked about the birth control and acne.
Right.
But although that is part of the guideline. But essentially the birth control is for one thing.
Right.
And we noticed that we got a lot of benefit from it. So now we're using it this way.
Right.
I hope that makes sense. But I know when we talk to patients off-label, and they start Googling, like it can get a little
tricky.
Yeah. So we just want to point that out. So let's talk about some procedures. Oh, and I did want to say, when we talk about like the frequency of urination, I don't think people are counting how often they pee. But I would say if you're going more than once in an hour, especially the 2 hours, I think most people, if you, like 2 to 4 hours is an expected range to return to the bathroom. So if you're going more than once in an hour, which we see in the hospital a lot, that's not normal, right? You should definitely talk to someone. Even every 2 hours, I would say is pretty frequent, especially when you go and you're not, and there's very, very little.
You didn't drink that much,
right? That means your bladder's not emptying, and that's going to put you at even greater risk for a urinary tract infection too. Okay, so we have some minimally invasive procedures. The first one is going to be called transurethral microwave thermotherapy. This is where they use a microwave to destroy that excess prostate tissue. And you had pointed out how important it is to talk to your provider because in addition to STI, and like I mentioned earlier, benign, meaning it's not cancerous, that excessive growth could be cancerous.
Right.
And while it's so much more common that men have a benign case where it's not, you always just want to be sure because it's one of our best cancers that we can treat, and it also typically grows really slowly. So you might get diagnosed, and we might not do anything for a long time because we're going to monitor, ever. Some men, they'll get diagnosed with prostate cancer and die from something completely different years, decades later. And so one of my teachers in nursing school used to call it like the good cancer to get, or she's like, anyway, she had a little thing, I can't remember anymore. One of the ones I'd rather get prostate than, another one. So don't be scared. And then we have the transurethral needle ablation, or also known as TUNA. They're using a radio frequency energy device to heat and destroy the tissue. All these are really just trying to minimize that tissue so you can open up that urethra and there's nothing blocking the urine from passing. Prostatic urethral lift. They put implants in to hold the enlarged prostate tissue away from the urethra. Water vapor therapy, where they use steam to destroy the tissue and make it smaller. And minimally invasive means usually we're just going to take a laparoscopic device with this tiny, tiny incision. They'll put the device through with a camera on the end, and they'll be able to see what they're doing. So if it's small going in, then the healing's supposed to be faster, downtime's supposed to be faster, pain's supposed to be less. That's what the minimally invasive. It's still a surgery. You still need anesthesia, your workup. You still need to sign consent. You can still have complications. They still might need to open you up later. But the goal going in is that it's minimal.
It usually doesn't require going under like general anesthesia where they like completely knock you out. So, or put you, out.
Alrighty. So I'm going to touch on a few of some actual surgeries that you may need to get if you have BPH. Some of these too can be, minimally invasive, but, they are a little more complicated. So we're going to start with the transurethral resection of the prostate, commonly known as a TURP. And it is the most common surgery where a portion of the prostate is removed through the urethra. Another option would be the transurethral incision of the prostate, or TUIP, which are small cuts are made in the prostate to relieve pressure on the urethra. Another option would be open or robotic assisted prostatectomy. Ectomy always means removal. Prostate is prostate. So that's removal of part or all of the prostate, typically for very large prostate or for complicated cases. And then there's also a laser surgery option, which utilizes techniques like the homonym laser enucleation of the prostate, or HOLEP, and photoselective vaporization of the prostate, which is PVP, which ultimately just means uses laser energy to remove or vaporize prostate tissue. I think all of these things, the things that Kimberly mentioned, the things that I mentioned, the whole goal is to either remove some of the prostate or do something with the tissue of the prostate to make more space for the urethra. That's just the bottom line. All of those techniques kind of do the same thing. So what could happen? What are some complications if BPH is left untreated? So what could happen would be urinary retention, and that's when we kind of already talked about, but the bladder isn't emptying fully, so urine is being retained in the bladder. And some complications of that really could be a urinary tract infection. You could develop bladder stones. I would probably say kidney stones, bladder damage, or kidney damage itself. All right, so because this is so common, we've all seen this out in the community, many, many times. So we thought we would just have some time where we would talk about what we're seeing out in the community. I could start a little bit, I still work inpatient. So we definitely still see patients coming in all the time with BPH. In fact, it's probably one of the more common histories. We're not always usually seeing them in the hospital, particularly with BPH, but they're coming in for something else, but BPH affects their stay. They may be in for diabetes, but they also have BPH, so it's something to consider. Or maybe they are there for BPH. But one thing to know is sometimes when you have that complication, that urinary retention, right? You're not able to get all of the urine out, but the urine still needs to come out, right? That can't stay. So in the hospital, there's a couple things that we could do, but we'll give you the medication. If that doesn't work, we're also probably gonna insert a catheter. It's not always the favorite thing for our friends. However, what we're hoping that we're going to have on the screen is a picture of what a catheter would look like. And basically, it's a technique that pretty much from a nurse to a nurse practitioner, providers, we can all insert these catheters. With folks that have BPH, though, there are specially tipped catheters that kind of help maneuver around that prostate so that it's a little bit more comfortable. I know in the institution that I work in, anyone over the age of 65 regardless if you have BPH or not, we're going to give you that specially tipped catheter. We call that a coude catheter, just to make insertion a little bit more comfortable, because the tip can be a little not large, but the standard size can be difficult with patients that have BPH. So that catheter is inserted into the bladder to help relieve the urine. And then sometimes you could go home with that catheter and you would follow up outpatient, and they'll do some trials to see if they remove the catheter and if you're able to urinate on your own. And that's usually, we'll put the catheter in, give your bladder some time to relax, get the medications going, making sure everything flows nicely, and then we'll remove that catheter to see if you're now able to urinate on your own with a better stream of flow. So that could happen while you're in the hospital, or we'll have you trial that outpatient.
And as far as like the outpatient settings, that's the setting I currently work in now. What we're basically doing first line is typically medications that we've prescribing the medications that we've already discussed, like the finasteride or the Flomax or tamsulosin. Also in the outpatient setting, we are assessing, and by doing digital rectal exams, which involves inserting the finger usually through the rectum to assess the prostate gland, and then also doing blood tests, like assessing PSA levels. And then from there, depending on what the levels are showing, further testing may need to be done if those levels are high, or if usually this is something that can be treated or managed in a primary care setting. However, if patients have complicated cases, we would refer them to urology, which is the specialist.
Yeah, I just want to mention that coude catheter, because of the way you can, hopefully you saw, the way it's shaped and it's like flexible, it can maneuver around that blockage, which is kind of what the other one can't do. And then you said, oh yeah, so that digital rectal exam. So I remember in NP school they talked about, I think I wrote something about it too, that it's limited on what it can actually feel.
Yeah.
And so that's an opportunity for you to really talk about whether or not you even want to have that experience, right? That is an experience with your provider, because there's other ways that they can actually assess and get images of the prostate that's a little more so the fuller picture.
Right.
So that's something to think about. Just like if you get diagnosed with anything, actually, it's something to think about. But yeah, so after the TURP, which is like the most common one, we saw everyone would come back with a fully placed by the surgeon, three-way catheter, can't remove it, right? If you have problems. Typically that's something nursing can, has realm over. They can do whatever they need to do within scope. But when you have that one that's placed by the surgeon, You don't do anything, right?
No.
Nope.
You always call, and then they're going to get the bladder irrigation, right? All those huge, it's bladder, right?
Continuous bladder irrigation.
Yeah, okay,
CBI.
great.
Yeah.
So the huge bags of fluid is going to be connected to that Foley, and it's going to, because there's a lot of blood involved, and so it's going to help flush out all that blood. So when you first come out, it might be, frank red, but the goal is to get it to like a nice pink tinge, and that's
lemonade.
That's what lemonade. So the nurse is going to be what we call titrating or adjusting how quickly that fluid comes out of the bag to get to that pink tint. In the course of that first night that you're there, typically we can get there by the morning. Some cases more complicated, might take a little bit longer, but that's why they're going to be running in there all the time. And it's a tough assignment because you're going in there a lot. And if you have your regular case of patients, it's a little bit stressful. That's what I remember.
Yeah.
And your bags get full quickly because there's a lot of fluid, constantly. So if you're not adjusting, you're emptying the bag. It's a lot of partnership with you and your charge and your care associates too, because they can help empty out the bags for you and stuff like that.
Oh yeah, that's true. Yeah. That was a lot. And then making sure you have enough bags, right? You get the blood clots.
Yeah.
Remember, you get the blood clots, and then you have to
pull back and
go back and forth. Oh man,
and those big bags always came from pharmacy, if I'm not mistaken. So you have to make sure you have enough.
You have to plan ahead to make sure you have enough bags.
Yeah.
And before you leave your shift, make sure your next nurse has enough to at least get started, right?
Yeah. I remember those days.
Okay, well,
so yeah,
I see a lot of that now. So I actually have it stocked on my cart. I don't have to call anymore.
That's what you do when you're the director.
Right.
But yeah, so for the patient, right, I mean, they might be a little, and if their family member's staying the night, they're going to be a little annoyed how often you're coming in there because, you're thinking, oh, they just had surgery, shouldn't they rest and get sleep and quality sleep without all these interruptions? And really, honestly, after that, any procedure, that's the time you need the most monitoring.
Yep.
It's temporary. We just want to make sure we avoid complications. And sometimes the best way to do that is to keep eyes on the patient pretty frequently. You can always ask for a sleeping pill if you're a candidate.
So we also want to just make sure that we're addressing all of our vulnerable populations. So we did discuss age, what age you are most likely to receive, or not receive, Lord, but the most to be experience, yes, BPH. We did address gender, but just to kind of reiterate, it is mostly going to affect, it is going to affect males that have male parts. So even if you identify as a male, but you do not have male parts, you will not experience or be affected by BPH.
Depending on what that surgery involved, right? Whatever organs are removed.
Right.
Yeah. I'm not really an expert on all the organs that get
I'm not sure. Yeah. That's a good point.
So that's a good point.
Yeah.
And the Flomax, because I've seen you take Flomax.
I have too, to help with urinary, but I don't see it often, but I have seen it.
Yes. As far as race, BPH affects all races. I don't think we specifically talked about anything related to our LGBTQI plus community, but we just mentioned it.
Just making sure that you're telling everyone, because especially now, depending on what system you use, I don't know, you guys are still using Cerner?
Yes.
Because Epic has a section where you can put the gender identity. Now, the last time I was at the bedside and I saw that, it was hidden, like you had to hit a drop down. So I think that could be improved. But even now in my current setting, when we have individuals like that, in my progress note, I put that up front what their pronouns are.
We do have preferred pronouns in the banner bar. So when you pull the patient's chart up, it has their preferred pronouns.
That's great. Yeah. And so just being honest about that when you request the room too, right?
Right.
Because your body's going to be exposed a lot.
That's true.
And if on the outside everything looks like one thing, and then you take the blanket back, that can be traumatic for you as well as a roommate. So just speak up. We can't make promises on what kind of room or bed you'll get, but we do try.
Yeah.
But I think the pronouns is a huge one, especially when you're talking, because if someone sees a body part but you don't identify with that body part, and you're already having this experience, that can be very traumatic.
Yeah.
And I know people are still trying to do their best in terms of being respectful. We just need to give grace on both sides.
Correct.
Right?
Yep.
So that's my piece on that one.
As far as socioeconomic vulnerabilities, I think this is going to affect. It's so common that I just think that it affects everybody,
Yeah,
no matter
everyone gets covered.
Yeah, no matter your socioeconomic background.
Yeah.
For multilinguistic,
oof, that's tough. You really want to make sure they understand.
Yeah, like this is very. I mean, like it's very common. So like it's
but it's also very invasive.
It is.
There's a lot of touching. There's a lot of touching.
Yeah.
And so depending on your religion and
the culture,
that's going to be a big thing. So you might need a family member.
Right.
And then it's like, sometimes it might be a different gender. You know how they have that?
Yeah.
And then it's like, when this time comes, they're going to leave the room.
Right.
So it's good to have that conversation, what you prefer. Because even the tech patients, people all the time will say, I don't want, it's typically male, that they don't want a male care tech, provider. Nurse or tech, so.
Education-wise, I think we covered that.
Yeah.
And then we talked about continuity of care and who to follow up with.
Yep. Yeah, because you might leave the hospital with that Foley.
Yep.
Yeah.
Until your follow-up.
Usually with a urologist.
Yeah, so you'll need to know how to care for it, signs of infection, obstruction can always, the risk for obstruction will continue.
Right.
And so you'll need to know what that looks like and what to do if that happens. As well as pain, if you're having pain.
Yeah. That's probably the most common thing I hear about is uncomfortability. It's uncomfortable.
And how to keep it clean, because you're the one going home doing that. You need to keep it clean.
Yes.
The nurse should be, I would get this question all the time. They would say the other nurse never cleaned it, but it should be getting cleaned at least once a shift. And if you're independent, we can teach you how to do it. You can do it yourself. We just encourage you to do it. Even if it's painful, we can try to do everything we can for the pain, because you can get an infection so easily. Because you have a foreign object in your body, and now you just open up the door. So bacteria before didn't have a way to get in, but now you just open the door.
Right.
So, and you just came out of a procedure, so now your risk is super high.
Well, to wrap up, we thank you so much, ladies. We discussed quite a bit today. We discussed the prostate and what it is. We talked about BPH and what that is, signs and symptoms of BPH, who can develop BPH or who's at risk for developing BPH, diagnosing BPH, treatment options, as well as the experience, our personal experience in the community.
Real quick. Yeah. And I just think because this is a men's health topic, we just want to encourage men to say they need help.
Right.
Because a lot of times a lot of these things that we talk about, people think it's a part of aging.
Yeah.
Right.
And yes, it is a part of aging, but you also have treatment options.
Right.
Yeah.
Especially because when you're talking about frequency, people won't leave their home.
Yeah.
They can't attend functions.
Because they're always going to the restroom.
And that's embarrassing, right? And so that speaks to your quality of life.
Yeah.
That can lead to anxiety, depression, and isolation.
Absolutely.
So on the first, it seems like this one little thing, but it has so many implications.
Absolutely.
And so we just want to encourage you to find someone that you trust so that you can talk about it, because we promise you're not alone.
It's more common than you think, so So as always, you can connect with us by emailing us your questions or show ideas at tmi.melanin@gmail.com. If you haven't already, please subscribe to our YouTube channel and follow us on every social media platform. Say hello in the comments when you get there. Please share the show with your friends, rate the Apple Podcasts and Spotify, as well as leave a comment. It really helps the show get more support and gets the message out there to those who need it. You can find all of our social media links and a list of resources related to our conversation today in the description box. We release a new show weekly on TMI Sundays at noon on YouTube and on all your favorite podcast apps. Follow, like, and share our content with all of your friends. Thank you for watching. Bye.
We'll see you next time.